We looked at the relationship of ACE score to absenteeism from work. As the ACE score goes up, the likelihood of absenteeism goes up significantly. Relationship to serious financial problems later in life, self-acknowledged, goes up significantly. Likelihood of having serious problems at work goes up significantly. So the number of realms in which this plays out are really major. And one might ultimately ask, okay, but how and why do adverse childhood experiences exert their influence throughout life? Why is treatment so difficult? Why don't people just get a hold of themselves and do better? I remember when I first went into practice, I was dismayed how often the problems that walked into my office didn't match the neatly ordered conditions that I had learned about over the years. And perhaps some of you have noticed that mismatch as well. This was a picture on the Journal of the American Medical Association about 20 years ago, looking through the dining room window of a family that eats together. Mother berating father, sitting there sullenly with knife upraised, kid kind of cringing over towards his mother. And I think most of us understand that if this is the scene night after night, it's not going to bode well for the kid. But why not? Why won't it work 30 or 50 years later for someone to say, oh, get a life. That was a long time ago. Get over it. These are two PET scans. A PET scan is a very sophisticated kind of X-ray that superimposes a picture of biochemical activity on anatomical structure. And these are two PET scans of the brains of two different 3-year-old boys, this one being an ordinary American kid, and this one being a 3-year-old male child taken from a Romanian orphanage. Many of you probably know that Romanian orphanages are the worst institution of their type in recent years, where the levels of neglect were really extraordinary. And what you see is that there are large areas of this brain where nothing is going on biochemically. And I don't think it's going to tax anyone's imagination to think that maybe at a time when brain is being formed, that this is going to affect the kind of brain that's formed. That is to say, we're looking at the translation of life experience, or in this instance, lack of life experience, into anatomical structure. And maybe this has a lot to do with why these things are so difficult to deal with later in life. Why people can't just, get a life, get over it. You could summarize what we've been talking about this way. You have this large base of people with adverse childhood experiences, many of whom will have some sort of disruption in the way their brain is formed. And this is a really important idea and relatively new. Producing some sort of impairment. It might be social, it might be emotional, it might be in their ability to learn in school. Producing, by the time they're teens, some need to do something to feel better. Tobacco works, alcohol works, sex works, methamphetamine works, food works. Each of those used heavily is highly likely to produce some sort of problem downstream. And so we see middle-aged people with diseases, disability, and social problems, and a number die early. And all of this is lost in time and further concealed by shame and secrecy and social taboo, because nice people don't talk about these things. So if we ask the question, what might we do to improve things in the future, to get from where we are now, which is not that impressive, otherwise we wouldn't be here, to where conceivably we could be, two things occur to us. One would be to acknowledge these problems exist. And right now there is major unawareness of that. And the other would be to recognize them in medical practice where they are rampant and overwhelmingly unrecognized. If you ask, well, what could we do today? I would say we could routinely seek a history of adverse childhood experiences from all patients by questionnaire. The questionnaire idea is important because to get this information is difficult. To do it comfortably is essential, and that's difficult, because with that experience, anyone is likely to be uncomfortable asking questions like this. So using a well-devised paper questionnaire or on the internet is really important, because it bypasses all sorts of problems that otherwise are likely to occur when the interviewer and the interviewee are mismatched in terms of age or sex or race, or the interviewer is worried about when the next patient is coming in, etc. I mean, few things will kill openness faster than discomfort on the part of an interviewer, whatever the reason is. Many physicians, of course, will say, well, yeah, but I mean, what do I do if I ask and somebody says yes? Here's what we have found to be a remarkably useful sentence to remember. Tell me how that has affected you later in your life. I see on the questionnaire that you were the one who discovered your father's body when he hanged himself. Tell me how that has affected you later in your life. I see on the questionnaire that you were molested when you were a kid. Tell me how that has affected you later in your life. It doesn't open Pandora's box. Interestingly, the answers are remarkably brief and concise and often contain information helping one know where one needs to go as the next step. You need systems to develop. You need systems to help with current problems. But most importantly, because of the magnitude of these problems, we need to develop systems for early prevention. And the fact is, no one knows how to do that. But it's a big step forward just to recognize that that's the right question. How does one approach the issue of primary prevention? I can tell you a little bit about our experience. This is a building I've worked in for a couple of decades. We have seen 1.2 million people for comprehensive medical evaluation since 1975 on the top floor here. And it's been an interesting experience. We, as a result of what we learned from the ACE study, we totally revised our medical questionnaire from a lengthy biomedical questionnaire that was filled out at home to a lengthy biomedical, psychological, social, and in particular trauma-oriented questionnaire that is filled out at home and then fed into a digital scanner that sucks up all of the yes answers and prints them out legibly. And it's had a profound impact on medical practice. We started asking routinely questions like these, you know, in addition to the conventional biomedical questions. Have you ever lived in a war zone? Have you ever been a combat soldier? Who in your family has committed suicide? Who in your family has been murdered? Who in your family has had a nervous breakdown? Have you ever been molested as a child? Ever been held prisoner? Ever been tortured? Particularly important where there are immigrant populations. Ever been raped? We have asked these questions of 440,000 middle-aged, middle-class adults over the past 8 years now. Obviously, it can be done. Do some people falsely answer no? Yeah, undoubtedly. The number of yeses we get, however, exceeds our capacity to deal with them, so we don't need to worry about losing some of the no's. What this has done, however, is that it's enabled us to understand and treat many problems that previously seemed intractable and incomprehensible. Here's a measure of what happened when we did this. Some years ago, when we were running the department on a purely biomedical model, in a 700-patient sample, we found that going through this comprehensive medical evaluation was associated with an 11% reduction in doctor office visits over the subsequent year. And I was pretty pleased. I thought, well, it goes to show, you know, more complete diagnosis, more efficient entry into a complex medical care system, et cetera, et cetera. And that was at least in large part true as an explanation. More recently, when we took what we learned from the ACE study and integrated that into daily practice, in a 120,000 patient sample, basically 2 years' work in this department, we found, or better yet, an outside firm found that there was a 35% reduction in doctor office visits in the subsequent year, an 11% reduction in ER visits, and a 3% reduction in hospitalization.